For decades, the psychiatric field has modeled attention deficit hyperactivity disorder around a single premise: a chronic, static impairment in dopaminergic neurotransmission. It is treated as a fixed neurodevelopmental baseline, but that baseline was constructed almost entirely from male presentations. Because of this, women are diagnosed an average of 4 years later than men, frequently presenting with internalized symptoms like severe inattention and chronic anxiety, rather than outward hyperactivity. Listen to female patients, however, and a clinical anomaly emerges. Their symptoms do not behave like a fixed baseline. They describe an experience that is highly dynamic and cyclical. Standard clinical models fail to account for these periodic fluctuations in cognitive function and mood. These periodic crashes in executive function and medication efficacy align perfectly with the physiological timing of the menstrual cycle. Continuing to treat ADHD in women as a flat, static condition ignores the biological reality of how ovarian hormones govern their cognition. Understanding these fluctuations requires analyzing the menstrual cycle as a potent modulator of brain chemistry. This graph shows characteristic fluctuations of ovarian hormones across a cycle. On the bottom axis, we track chronological phases: follicular, ovulatory, luteal, and premenstrual windows. The solid line maps estradiol. The dashed line tracks progesterone. These two waveforms dictate the cognitive shifts female patients experience. Because dopaminergic systems are highly sensitive to these exact hormonal tides, their interaction provides a direct neurobiological mechanism for why working memory and attention vary throughout the month. This leads to a crucial tension in the data. Why do these exact same hormonal waveforms create minor, manageable shifts in neurotypical women, but severe cognitive vulnerability in women with ADHD? We first need to establish the baseline relationship between hormones and neurotransmitters. Generally speaking, estrogen enhances dopaminergic activity. When estrogen levels are high, the dopamine signaling becomes more robust, priming the brain for demanding cognitive tasks. Progesterone and its metabolites, like allopregnanolone, primarily influence GABAergic activity. This system modulates neural inhibition and promotes physiological calm. Look closely at the mid-luteal phase, where the dashed progesterone line reaches its peak. Data from Brotzner, Alkanot, and Shu reveal that during this window, neurotypical women experience enhanced spatial attention, divided attention, and cognitive flexibility. These objective attentional boosts correlate directly with rising progesterone. In a neurotypical brain, the mid-luteal phase triggers compensatory neural adaptations. The brain successfully balances the hormonal shift to maintain or even boost cognitive performance. When we examine clinical populations, specifically women diagnosed with ADHD and premenstrual dysphoric disorder, or PMDD, that pattern reverses. We are looking at the exact same mid-luteal and premenstrual hormonal windows that produced cognitive enhancement in the control groups. Here, the data nodes for attention and executive function drop, plummeting downward. Instead of a cognitive boost, ADHD and PMDD cohorts exhibit significantly decreased attentional control and severely impaired executive function. Simultaneously, impulsivity spikes sharply upwards during the same luteal window. The effect is compounding. Individuals dealing with both ADHD and comorbid mood disorders like PMDD suffer the most severe impairments. These objective clinical measurements validate what patients have been reporting for years: intense brain fog and heightened emotional dysregulation consuming the luteal phase. The ADHD brain fails to execute the compensatory neural adaptations seen in non-clinical populations, turning a biological rhythm into a severe functional deficit. What specific neurochemical failure links normal ovarian fluctuations to the core dopaminergic deficits of ADHD? Researchers point to two primary mechanisms. The first is the estrogen withdrawal model. As the supportive presence of estradiol steeply drops off in the perimenstrual window, so does its boosting effect on neurotransmitters. This withdrawal strips away baseline neurochemical support, unmasking and dramatically exacerbating the underlying dopaminergic deficits already present in ADHD. The second proposed mechanism is the allopregnanolone sensitivity model. Here, peaking progesterone and its metabolites trigger erratic interference in GABAergic modulation. Women with ADHD and PMDD appear to have an altered neurological sensitivity to these metabolites. This disruption effectively removes the protective neural adaptations that maintain calm and focus in neurotypical women. Whether driven by dopamine withdrawal or GABAergic disruption, these hormonal tides actively sabotage the delicate neurochemical balance required for baseline executive function. These mechanistic failures dictate the practical reality of clinical treatment. Currently, the gold standard for ADHD pharmacotherapy relies on a fixed daily dosage of stimulants, prescribed entirely irrespective of the patient's biological sex or cycle phase. This brings us to the premenstrual window. During this specific window, clinical data confirms the subjective reality of the patients. Standard medication efficacy significantly diminishes. For many, the fixed dose becomes insufficient. A recent community case study by DeYoung and colleagues tested a direct, dynamic intervention to counter this phase-specific drop. By actively increasing the stimulant dosage specifically during the premenstrual week, patients experienced improved ADHD and depressive symptoms with minimal adverse events. Prescribing a static, unchanging medication dose to treat a dynamically fluctuating neurochemical disorder is biologically unsound. While the current literature features methodological heterogeneity and small sample sizes, the overarching pattern across 29 distinct studies is undeniable. Core ADHD cognitive functions, from working memory to inhibitory control, are inextricably linked to the physiological timing of the menstrual cycle. We must translate these theoretical insights into clinical application, implementing female-specific diagnostic procedures and flexible, dynamic dosing strategies. True equity in psychiatric care requires abandoning the myth of the static baseline and finally treating the female brain in harmony with its own biological tides.